It gives me a pleasure to open our afternoon educational session, Fine-Tuning Risk Assessment and Risk Reduction. I'm Banu Arun. I'm a breast medical oncologist and Director of Clinical Cancer Genetics at the University of Texas MD Anderson Cancer Center. Today, we have three distinguished speakers who will be tackling the area of risk assessment and risk reduction for breast cancer, including harnessing lifestyle interventions via diet and exercise for cancer risk reduction, emergent pharmacologic interventions for prevention, especially non-endocrine therapies, and then finally, a lecture about virtual artificial intelligence and imaging. With this, I would like to introduce our first presenter, Dr. Neil Iyengar from Memorial Sloan Kettering Cancer Center. He is joining us in person. He will be talking about harnessing lifestyle interventions via diet and exercise for cancer risk reduction. Dr. Iyengar.
Okay, thank you very much, Dr. Arun, and I'd like to thank the conference organizers for the invitation to speak today. As you heard, I'll be discussing lifestyle interventions, and I'll be specifically discussing how we might be able to fine-tune, as it were, our risk assessment in terms of metabolic health and matching lifestyle interventions to the appropriate risk. Today I'll be sharing data from the post-diagnosis, post-cancer diagnosis setting, but I think we can learn a lot from that data in terms of how we can apply that to the risk reduction setting. So you may be seeing me straddle both ends of the cancer continuum, but again, I think that we can learn a lot from the post-diagnosis setting when it comes to the intersections between metabolic health and cancer development. Here are my disclosures to start. So this is a bit of a busy slide, so allow me to orient you to it. I think we're all well aware that obesity, classical obesity, is associated with the development of several different cancers, 13 cancers to be specific. And I say classical obesity because obesity is typically defined by body mass index of 30 or greater by the WHO criteria. And here you can see recent data that was published in 2019 showing an association between obesity and 13 different cancers. Perhaps more alarmingly is that the incidence of these obesity-related cancers is on the rise among younger cohorts. So again, I know you can't read some of these plots, but let me draw your attention to the color schema in these plots. The orange boxes, which are at the top of a lot of these plots, indicate the eldest cohorts, which are ages 80 to 84. The blue cohorts, which are at the bottom of these plots, are the youngest cohorts, ages 20 to 24. And essentially, what you could see is, as we might expect, the incidence of all of these cancers is highest among the older cohorts. However, what I'd like to draw your attention to is the slope of these curves. If you look at the slope of the curves of the elder cohorts, we can see that several of these lines are downtrending. So this first plot, for example, is breast cancer. Here we have colorectal cancer. Whereas if you look at the younger cohorts, we see an uptrend in the incidence of these cancers despite this very young age of 20 to 24. And this is alarming because if projected out, the burden of these obesity-related cancers will rise with time as these cohorts age. Now, I mentioned at the beginning of the talk that we're going to focus on how we can fine-tune our risk assessment in terms of metabolic risk. If we take a step further beyond body mass index and we look at body composition, we get our first clue that perhaps it's adiposity, or the amount of body fat that could be driving the association between obesity and cancer risk. So these are data from the Women's Health Initiative, which was a prospective cohort study that enrolled at 40 centers across the United States. And several of these patients received DEXA scans, which is a gold standard for measuring body composition at baseline. All of these patients had no cancer diagnosis at baseline, and this forest plot is showing you the association between whole body and trunk fat mass with the development of invasive postmenopausal breast cancer. And you can see that individuals in the highest quintile of whole body fat and trunk fat mass had a higher risk of developing postmenopausal breast cancer, particularly those in the highest quintile of trunk fat mass. Now, this may not be particularly surprising, as we do anticipate that body fat levels are going to be higher in obese individuals, that is, individuals with higher body mass index. But as I said earlier, this gives us a clue that perhaps adiposity is driving that obesity-cancer relationship. So our group and several others have been interested in the mechanisms through which adiposity drives the development of cancer. And through a series of studies, which I won't go through in detail today, but I will summarize here, we've shown that hyperadiposity is associated with an inflamed proestrogenic microenvironment that is essentially ripe for the development of tumor growth. I'm going to show you data in breast cancer. And as we know, the breast is largely comprised of adipose tissue, with the tumor directly interfacing with this adipose tissue. In the context of metabolic disorders, adipose tissue inflammation has been described to occur in visceral fat pads and associated with increased risk of developing diabetes, coronary artery disease, and other metabolic disorders. This is a cartoon depicting at the histologic level what adipose tissue inflammation looks like, or how it can be detected, by a crown-like structure. So essentially you see a diseased adipocyte that is surrounded by activated macrophages, which are attempting to clear that diseased adipocyte and instead forming a highly inflammatory lesion within the fat pad. This is what it looks like, crown-like structures, by CD68 staining, which of course is a macrophage marker, and H&E staining. And in 2011, we published the first data of the presence of this adipose tissue inflammation in the breast fat, so a non-visceral adipose tissue depot. Through a series of translational experiments, we showed that the presence of adipose tissue inflammation, or crown-like structures, was associated with increased levels of pro-inflammatory cytokines at the local level, which can directly stimulate tumor cell growth, as well as CYP19 and aromatase transcription, with aromatase, of course, being the rate-limiting enzyme in estrogen biosynthesis. And in a retrospective cohort study, we found that the presence of crown-like structures in the breast fat is associated with a worse distant recurrence-free survival after breast cancer diagnosis compared to women without adipose tissue inflammation. So what about the risk setting? These are data that were published by a group at Mayo Clinic, which looked at adipose tissue inflammation in a case control study and the development of incident invasive breast cancer. And essentially what they found was the presence of adipose tissue inflammation in patients with benign breast disease was associated with an increased incidence of invasive breast cancer. And the severity of adipose tissue inflammation, which was quantified by the number of those crown-like structures, was associated with a higher incidence of invasive breast cancer. So we see that this process is indeed relevant to the risk setting as well. Now, one of the things that our group has been particularly interested in is whether or not this phenomenon is active in patients who may not be recognized to have classical obesity. This is data from one of our prospective cohort studies, and you can see here that the vast majority of classically obese individuals with a BMI of 30 or greater have adipose tissue inflammation, and the majority of overweight individuals, more than 50%, also have inflammation. However, intriguingly, about 1/3 of individuals with a normal body mass index also have adipose tissue inflammation in the breast, and this has been recapitulated in other cohorts as well. So in collaboration with Dr. Christy Brown and her laboratory, we were able to look at this adipose tissue inflammation and aromatase in normal weight individuals. And what you can see here is that individuals with adipose tissue inflammation detected by CLSB have higher aromatase levels despite having a normal body mass index. And you can see even a dose-response-like relationship with the severity of adipose tissue inflammation. On the bottom are representative immunofluorescence sections. On the left is an individual without adipose tissue inflammation, and on the right is an individual with adipose tissue inflammation. Red is highlighting aromatase, and you can visually see the aromatase highlighted in red in the individual with adipose inflammation despite having a normal body mass index. So we went on to further interrogate the Women's Health Initiative data and look at the relationship between adiposity and breast cancer risk, specifically in individuals with a normal body mass index. So again, all of these individuals had no cancer diagnosis at baseline, and we focused in on those with a normal BMI who received a DEXA scan to measure body composition. Here you can see that individuals in the top quartile of whole body fat had an increased risk of developing invasive postmenopausal breast cancer, and this was any subtype of breast cancer, though the association was stronger for estrogen receptor positive breast cancer. In terms of trunk fat mass, we see that individuals in the top half, or the top 2 quartiles, have an increased risk, over a doubling in their risk of developing invasive breast cancer, again, despite having a normal body mass index. Clinically, this is important. I'm going to show you here now 2 representative DEXA scan images from 2 individuals. These are actually patients of mine who've agreed to share their images. They both have the same body mass index of 24, which would be considered to be a normal BMI, albeit on the higher end of the normal spectrum. And just looking at the DEXA images, you can already detect a difference despite when you look at these individuals anthropometrically or visually, it's hard to detect a difference. So the individual on the left here has a total body fat level of 39% with 44% truncal fat, while the individual on the right has even higher, 60% total fat and 59% truncal fat. And perhaps surprisingly as well, this individual is premenopausal as opposed to this postmenopausal individual on the left. So again, if we were to use classical metabolic risk assessment measures, essentially visual inspection and BMI, we wouldn't detect this increased cancer risk that has been associated with these levels of body fat. And we may in fact guess that the postmenopausal individual has a higher body fat percentage, whereas the DEXA scan reveals different findings. So again, here we're seeing that we can fine-tune our metabolic risk assessment by using tools that go beyond body mass index. Our group and other groups have shown that this adipose tissue inflammation occurs in multiple organ systems, and therefore the adiposity-derived or adiposity-directed cancer risk may apply beyond just breast cancer. So, for example, we have reported that adipose tissue inflammation in the tongue is associated with worse outcomes for patients with oral squamous cell carcinoma. I showed you the breast data. We have also reported that patients with periprostatic adipose tissue inflammation have higher grade prostate tumors, and so on for several other organs. So this raises the intriguing hypothesis that measuring adipose tissue or adiposity as well as adipose tissue function may be able to better improve our metabolic risk assessments for obesity-related cancer risk. There are several mechanisms that may drive this relationship. We've talked about the microenvironment, but of course there are multiple systemic pathways that are also dysregulated in the setting of hyperadiposity. For example, we see insulin resistance and higher levels of pro-inflammatory circulating cytokines, as well as higher levels of bioavailable estrogens, which all generate a host environment that is also pro-tumorigenic. One of the things that our group and others are also interested in studying is whether or not we can develop a blood-based biomarker signature of adipose tissue inflammation, which may be able to predict what's happening in the tumor microenvironment. So essentially, we need to think about tailoring our approach to obesity and how obesity relates to cancer risk. I think it is now well recognized that classical obesity is one of the leading modifiable risk factors for several different cancers. it is also now becoming fairly well recognized that metabolic obesity in normal weight is associated with an increased risk for metabolic syndrome disorders. But we are also now seeing emerging data, such as the breast data that I showed, suggesting that metabolic obesity in normal weight is also associated with increased cancer risk for breast cancer, colorectal cancers, and perhaps several other classically obesity-related cancers. So what can we do about it? Well, now I'm going to shift into the latter half of my talk, which will discuss lifestyle interventions and how we can think about fine-tuning lifestyle interventions to reduce cancer risk. These are recommendations from the American Institute for Cancer Research, and I like these recommendations because they are updated every couple of years based on the state of the data. And essentially, you can see some of these recommendations are straightforward: maintain a healthy weight, be physically active. The dietary recommendations are perhaps the most specific of all of the currently available dietary recommendations. So here we see eat essentially a plant-forward diet that's rich in whole grains, beans, fruits, and vegetables, and avoid highly processed foods, red meats, sugary beverages, and alcohol consumption. These recommendations have been validated in cohort studies, which have shown an association between adhering to these recommendations and lower risk of developing several types of cancer. This is perhaps one of the largest analyses that specifically looked at exercise or physical activity and cancer risk, that was published in JAMA Internal Medicine in 2016. And I like this particular analysis because it is stratified by body mass index, less than 25 normal, or overweight obese 25 or greater. And essentially what you can see here is that for multiple different types of cancers, there is an association between increased physical activity and lower risk of developing those cancers. Now, perhaps what's intriguing here is there are two cancers, prostate cancer and melanoma, where increased physical activity was associated with what we would think is counterintuitive, a higher incidence of these cancers. But subsequent data has demonstrated that this analysis was perhaps confounded by the observation that patients who engage in a healthy lifestyle are more likely to undergo prostate cancer screening. So there is some screening bias here, as well as receive more sun exposure, which might account for the increased risk, or the increased incidence, I should say, of these cancers in this cohort. Nonetheless, we see as a whole evidence to support a relationship between physical activity and reduced incidence of multiple cancers across the spectrum of BMI, including those with a normal body weight. Our data also supports the hypothesis that exercise can reduce the risk of cancer. This is specifically with regard to adipose tissue inflammation. So we've reported that across the entire spectrum of body mass index, patients who report higher levels of physical activity are less likely to have adipose tissue inflammation. And when we look specifically at the normal BMI individuals, we see essentially the same relationship. Again, that patients who report higher levels of physical activity are less likely to have adipose tissue inflammation. So this has led us to conduct a series of studies, many of which are ongoing right now, that are testing various diet and exercise interventions, mostly in the post-diagnosis setting. But as I mentioned earlier, we hope to take some of these learnings to the risk setting. One thing that I want to mention before getting into some of those is that the rate and amount of weight loss do seem to matter. So this was a small pilot study that we conducted in patients without a cancer diagnosis, and these were all obese postmenopausal women. And they consumed a very low-calorie diet for approximately 6 weeks. This was about 750 kilocalories per day. The average amount of weight loss was about 10% of baseline weight over the course of 6 weeks. So this is very rapid weight loss. And essentially what we found was circulating metabolic and inflammatory factors like lipids and pro-inflammatory cytokines improved with this weight loss. However, in abdominal subcutaneous fat pad biopsies, we found more adipose tissue inflammation after the intervention. So this is a representative section at baseline from an individual who participated in the study, and here's the post-intervention section. And what you can see here are greater numbers of these crown-like structures in the abdominal subcutaneous fat after this rapid amount of weight loss. So again, this supports the notion that rapid weight loss is not necessarily something we should be recommending to our patients. In addition, there are other studies that also support these findings. For example, in prostate cancer, rapid weight loss has been associated with a rise in Ki-67 in prostate tumors. So I want to move away right now from caloric restriction and talk a little bit more about specific dietary patterns with the concept that we can apply a precision oncology paradigm to the development of lifestyle interventions. We are interested in specific types of diets, for example, a plant-based diet, and the effects that it may have on biology as well as cancer risk reduction. In addition, pairing these types of specific diets with exercise and exercise prescriptions to modulate specific biologic pathways that we can target based on a patient's risk profile. So I mentioned the plant-based diet, and this is currently recommended by several professional bodies, including the AICR. And there is a scientific rationale for adhering to a plant-based diet to reduce cancer risk. For example, here are data from the Nurses' Health Study, which categorized dietary intake as a healthful plant-based diet versus an unhealthful plant-based diet. And I think this is an important distinction because, of course, we could be eating potato chips and donuts and call ourselves plant-based, but that's probably not congruent with the type of healthy diet we should be consuming. And what you can see here is that individuals who consumed a healthful plant-based diet, that's the light gray bars, had lower levels of leptin and adipokine that can directly stimulate cancer growth and through multiple other pathways also promote cancer growth, as well as lower levels of C-reactive protein, whereas individuals who consumed an unhealthful plant-based diet had higher levels of pro-inflammatory cytokines, adipokines, and IL-6, for example. There's a lot of numbers on this slide, so I don't necessarily want you to read this, but I put this up here because this I thought was an interesting meta-analysis which suggested that lower meat consumption is associated with lower circulating estrogen levels. This was a meta-analysis that looked at 2 studies which were actually testing different amounts of soy in the diet. And when the data were pooled, what the investigators found was that individuals who were what they called semi-vegetarians, which were the lowest amounts of meat consumption, had lower levels of these serum estrogens compared to non-vegetarians or those who consumed higher amounts of meat. And this was independent of soy intake. So the soy question comes up frequently, but essentially the bottom line here was that lower levels of estrogen, circulating estrogens, were found in patients who consumed less meat, and and the amount of soy intake did not impact this association. So based on these and other data, we're now testing the combination of a plant-based diet with structured exercise for patients who've been diagnosed with hormone receptor positive primary breast cancer. We're randomizing patients who are being treated in the adjuvant setting with an aromatase inhibitor to a structured exercise plus plant-based diet arm. So in this arm, we're sending a treadmill to the patient's home and conducting video-supervised home-based exercise sessions with a specific exercise prescription that's aimed to generate a personalized caloric deficit. In addition to meal delivery of whole food plant-based meals that patients essentially warm up and consume with nutrition counseling. The control arm is an attention control arm, which combines telephone counseling. So we do ship a treadmill to the patient's home so they have access to the potential for exercise, but it's essentially self-directed exercise, plus nutrition counseling that's done over the phone without the meal delivery, again, self-directed dietary change. And the primary endpoint is to look at biological changes in the breast tissue with several other planned secondary endpoints. And again, we hope to take the learnings from this post-diagnosis trial to better, to fine-tune again our recommendations in the risk reduction setting. So what can we say to our patients currently? Well, I think based on the state of the data, we can say that beyond maintaining a healthy weight, one should also maintain an optimal body fat and lean mass ratio. And patients will often ask, well, how can I assess my body composition? There is actually a diagnosis code that is available for reimbursement through preventative medicine that allows for ordering of DEXA scans to measure body composition. I will note that it requires a different type of software, so unfortunately right now you can't get body composition from a DEXA scan that's been done for bone density purposes. In addition, for overweight and obese individuals, the data currently suggests that the safe rate of weight loss is 1 to 1.5 pounds per week. For now, we should be encouraging healthy eating patterns, for example, a plant-forward diet, rather than very specific diets, for example, the ketogenic diet, which, by the way, we are testing, but in a very, very biologically specific population. For now, I would recommend a plant-forward eating pattern. Encourage physical activity, of course, predominantly aerobic activity, but data do support recommending resistance training to support bone health. And there are some ongoing studies that are looking at the anti-cancer effect potential of resistance training as well. And finally, there are several programs that we can recommend to our patients, such as meal delivery programs that are commercially available, of course, the diabetes prevention program, the Livestrong program, and a program that we're developing at MSK called the Healthy Living Program, which aims to rapidly translate these findings from the research setting into the clinical setting. I won't go through all of this here because Dr. Shen presented preliminary findings from our first 200 patients in this program at a poster session this morning, which is currently available online. But essentially, we're looking at the application of a personalized lifestyle risk assessment tool in order to match personalized lifestyle prescription plans with dietary, exercise modification, as well as psychosocial interventions as well. So with that, I'll conclude and thank my many collaborators and funding sources, and thank you for your attention.